My name is Ray Singer. I'm the Chief of the Division of Cardiothoracic Surgery and Vice Chair for Quality and Patient Safety at Lehigh Valley Health Network in Allentown, Pennsylvania.
I'm Speir. I'm a cardiothoracic surgeon and head of the program at the Inova Heart and Vascular Institute in Falls Church, Virginia, and chair of your workforce on healthcare policy, advocacy, and reform.
Doug Mathisen, past president of the Society of Thoracic Surgeons, general thoracic surgeon at Massachusetts General Hospital in Boston, and head of the Health Policy Council.
Kevin Accola from Orlando, Florida, at Florida Hospital Cardiovascular Institute. I'm in private practice in Orlando, and we'll look at that aspect from a private practice perspective.
I'm Keith Naunheim. I'm a thoracic surgeon from St. Louis University Hospital. I'm also the secretary of the STS.
One of the issues that we faced in the past year was the elimination of 10 and 90-day global payments. And there was at least a threat at one point that all cardiothoracic surgeons were going to have to document their time in the postoperative care of patients on 10-minute increments, if you could believe that. And that has been held off. But tell us a little bit about what is going to take place in those 9 states and the survey that's going to follow for most cardiothoracic surgeons starting, I believe, in June or July of this year. Could you mention something about that?
That's a very important area, and it's while a little bit beyond the compensation in and of itself. As part of the macro bill, the maintenance of our global payment structure was able to be preserved, and this was due to a lot of work on behalf of the Government Relations Office in Washington and Courtney Yeo and her group that were able to maintain our global reimbursement as we know it, to include the episode of care in the operating room, the perioperative care in the intensive care unit, and then the step-down units and the care out to 90 days. The plan was then to go at risk for the ICU and the step-down care. That was able to be preserved as we know it, but the pushback on the part of CMS is that all the surgeons would have to document their work product, and it was going to be divided in 10-minute increments for thoracic and cardiac surgery. And the thought being that the longer that you spend with the patients, the more work that you are actually delivering, the higher the value. That was the proposed rule, but recently in the summer, that was actually in the final rule marginalized to, and I don't know the exact states, but I think we were going to have that presented on our website in which the physicians, all of the physicians, but particularly in cardiac and thoracic for bypass valves, lobectomies, will then define and document in the chart what their actual work was. It can be through extenders, but it has to be the physical presence of the surgeons. And this is still being worked out. There are many of these answers that are not straightforward as of the June of 2017 or January of 2017, and we are working actively to begin to define these more carefully, as is true with the alternative payment, and that will be made available to our membership both through publications, but particularly the website under Courtney's direction.
Let me just say that the potential consequences of that are grave. Many surgeons, most surgeons I believe, feel that their job is, a lot of their job, 80–90% of the value of what they do is in the operating room. But as it turns out, according to CMS and the Relative Uptake Committee, the way you are paid is calculated on your intraoperative work and your postoperative work. And your postoperative work is at least 50% of your fee. Half of what you get paid is in the postoperative period, both immediately in the hospital and for that 90-day period of care thereafter. The risk is that if you don't document that in these states where they're going to be keeping track, they can say, it's not documented, you didn't do it, we're not going to pay you all. These people are essentially they're the mice in the lab experiment. We are all going to get paid with regards to the results of this. If they only document 25% of the postoperative care, it's very possible CMS will start to pay us only 25% of that 50% that involves postoperative care. We need our constituents to document all the care they're giving. Many of the arguments from Medicare have been, oh, you guys aren't doing it, the cardiologists are seeing the patients post-op, the ICU people are giving the care. And we know from our own surveys that we're actually giving care, and that, yes, cardiologists in some cases and ICU physicians are, but we provide critical care and post-operative care as well. But if we don't document it, we are at risk of losing a significant amount of our surgical fee by a royal fiat from CMS. So those people who are in the States have to provide that documentation, otherwise they are at significant economic risk.
I think that's what distinguishes cardiothoracic surgeons from some other specialties, if I may say, because we are much more engaged in the post-op care. We all know that post-operative care has become complex. You mentioned intensivists, you mentioned cardiologists, but in many institutions there's hospitalists who take care of patients, let's say, after an orthopedic procedure, after a neurosurgical procedure. I think it's fair to say that as cardiothoracic surgeons, we've always historically been much more engaged in the post-op ICU care management. And to your point, this is the time where we have to document it, because these are changing times. And we want to make sure that, that we are recognized and rewarded for what we do.
Of all the messages that we could probably leave with as a result of this roundtable, I think your message is the sentinel one. Regardless of what is happening in those 9 states, all of us should begin to pay very close attention as to what the intent is of this endeavor, and begin to already tailor our practices in thoracic and adult cardiac and congenital to achieve these ends.
Just to reassure the membership, the 9 states have been identified. The surgeons in those states will be identified. They'll be contacted by our Washington office, explaining the process, alerting them, walking them through the process, what to pay attention to. It will definitely be a change in behavior. Clearly people take care of patients, but they probably aren't used to documenting their care, and that will become increasingly important. The follow-up is a survey, which will be more broadly distributed throughout the country. And again, once more details about that are available, it'll be disseminated to the membership. So you need to be aware of it. There will be multiple ways in which we'll communicate that message, through the website, through the newsletter, to make everyone aware of this and be ready for it, because it will become a very important activity. Kevin?
Yeah, a lot of times these surveys get overlooked. We all get those things. We go, well,
Right.
Someone else will take care of it. There's not a more important time than ever before for everyone to actively participate. And our Washington office is so incredibly strong and good and helpful with any questions. And so I would encourage our membership to contact them either through the website or through the office phone lines. I think that now more than ever we have to raise the torch and be active and participate in these things.
And that includes employed physicians.
Absolutely.
The tendency is for employed physicians to say, well, it's somebody else's problems, it's the hospital. This is our problem.
There'll be a ripple effect.
This is our time. This is our time as cardiothoracic surgeons to step up to the plate, try to understand the language, take care of the things that we can control. And there are many things we can control. This is not someone else's problem. This is our problems. You need to support what we're doing.
Keith or Alan, either of you want to comment on some of the educational plans to try to educate the membership about these very confusing issues, and where that stands, and where people can expect to hear some of the educational activities that will go on to try to have a broader and better understanding of these issues?
Yeah, we'll be working through both our Washington office and our coding and reimbursement office. There will be, we have, as you know, a yearly, an annual coding seminar. There will be a lot of information there. Through the Washington office and through the STS Central office, there will be educational webinars, and there will be educational information being sent through multiple different areas, through STS, through our STS website, the STS News. We will link to websites where we can give you step-by-step instructions as to what you should be doing and how you should be filling in forms. It is going to be, I believe the technical term is a pain in the ass, but as Ray said, it's our pain in the ass, and if you don't do it, you're cutting your own throat. This is a time when you cannot be irresponsible and saying, oh my God, it's paperwork, somebody else is going to do it. You do that at your own risk, and it's severe economic risk. A MIPS, you do a lousy job on the MIPS, bam, you get hit with 3%. You do a lousy job on post-operative documentation, you're talking about a 25, 30, 35% cut in pay. And if that happens to you, it's your own fault if you didn't do the work.
By doing a lousy job, you're not meaning poor.
No, I have
patient
nothing. It
care.
has to do with
Nothing to
paperwork.
do with
It's a
that.
pain in the
It's all
rear.
documentation.
It's
I think
all
that's what the
documentation.
people have to understand.
Absolutely. There's high quality surgery going on in every state. The vast majority of cases that we do, we are doing a great job. But if we don't document it, they're going to call us on it.
Without documentation, it's as if it never happened to the government. And I think that's an important message. The membership should be reassured that the specialty, the society, takes this issue seriously. There's going to be a lot of effort and energy put into educating, making resources available so everybody understands these things and not caught off guard by it, because it really is an important issue.